Okay, let's start again the second session. This room is a little bit, warm, so I take off my jacket. So please excuse me. And I have some announcements before that why we prefer to use that MBT's prescription. Especially, it's a little bit important that the bracket, which way the bracket was produced, to think in FA point as a reference or same kind of cusp as the same distance to determine the height. Yeah, as you can see here, if you put in an x value and then the final bracket position after leveling and alignment, the bracket slot plane is parallel to both upper and lower. But if you selected the FA point, the position, this looks like it's kind of has a divergency. So from the back to the front, this one is lower, and the central incisors, especially the upper, is bigger in the height here. So the wire's position is like a divergent from the back to the front. It is much. It looks like a divergent like that. And then with the FI point, the canine, especially the canine, the height becomes more longer, more bigger from the cusp tip of the canine, and it is tendency to go position more and gingivally. And as you can see, the bracket, many very well made bracket, has a difference in thickness from the bracket slot to the bracket basis. So the canine bracket, especially in the lower, it is very important to have a kind of curvature accommodated the surfaces of the tooth, and at the same time, the thickness should be minimum in canines. It is very important, but when you put up but the clear bracket, resin or ceramic, has a very compared to the metal bracket, it is weak, so it must be a little bit thicker than metal bracket. So it is very difficult to make very thin bases in the canine, number one. But they try to find out the most accurate thickness while maintaining the strength of the bracket. Anyway, but it is much bigger than in metal bracket. Some metal bracket has almost the same distance here, as you can see here, but it is very difficult to make between 32 and 33, for example, lateral incisors on the lower and the lateral canine. And when you put in the bracket, especially the clear bracket in an FA point, it has very, very long weight from the cusp tip here, and then it tends to push the canine more lingually than usual. So after leveling, as you can see here, there looks like some step here. Canine tends to tip or move lingually a little bit more, and there is a little bit of steps between medial to canine and distal to laterals. So in that many reasons, maybe to put on instead of the FA point, especially MBT prescription was made of the same distance as, as a kind of reference to the cusp tip, and rather than FA point, sand withdrawal using a X value bracket placement is much beneficial to minimize this kind of, medial step here between here, to minimize that kind of happen. So it is nothing to do with which companies this is a tendency. So without interfering the upper teeth and the lower brackets, bring the canines more higher, then maybe you can minimize some kind of irregularities. And that is a one important factor. If you use the ceramic or aesthetic bracket or self-propagation, has more profile because of its structure and composition of that. So I hope that you understand what I'm talking about. Yeah, this is another clear example that from the lower bracket and the very lower in the canine, and they automatically produce some kind of step like this one. So if you meet this kind of situation, you have to make a small kind of first order band and here so even though with your very expensive straight wire appliances, if this kind of situation happen, then you have to bend wires, or later on, maybe after debonding, maybe you can use the clear liner, whatever, and then you can fix this kind of unwanted thing happen. Okay, yeah, talk about some kind of steps in modern fixed orthodontics. Because of the use of the minuscule, now it is kind of controversial that we have to, especially in non-extraction cases, we have to move the molar first or not. So some people thought this kind of things as a sagittal first or sagittal later. But I would like to tell you that for me, that if you put on a bracket, nowadays, if you fall into the non-extraction, we are leveling first and then move the teeth posteriorly or anteriorly later with a very thick finishing arch wire is placed with the help of the minuscule. So number one is that step one is so-called, we have to do leveling and alignment. It's the kind of intra-arch movement. Mostly it was done by the rotation control. Crowding, also make a space, and then we have to deal with the rotation of the teeth. So let's take a look at the leveling and alignment first. In a textbook, especially, and you can refer to the contemporary orthodontics, the passed away Robert William Prophet. He collected very good information of that. And it said that in the textbook, we have to move the crown rather than root first. So that's why we start with a round wire rather than a rectangular wire. And to give a slide of the tooth movement, if the very irregular teeth come to straight line, then maybe the wire slipped out without any friction or resistance sometimes. So to sliding well, we needed a 0.004 inches clearance between the bracket slot and the wire. At the minimum, at least we have to 0.002 inches clearance needed, and the teeth must be very flexible, not too rigid. So in the past, they compared to the 016 night tie, that 014 stainless steel with the loop, and like this one gives a very similar stiffness with 016 night tie wire, or 016 stainless steel. You need a very long hook and helix here to lengthen the length of the wire between the bracket, so it gives a more range and it reduced the rigid stiffness of the wires, and it gives act like the same forces and range. And we do need a sequential wire change from small and very flexible wire, and it's getting more and more thicker and stiff wires. And because of we very seldomly use the rope in treating our cases, especially extraction cases. We are prepared to use the sliding mechanics nowadays in the straight wire appliances. And our goal is leveling alignment is that to put on a 1925 stainless steel in 022 bracket slot. Because in sliding mechanics, in a train, the rail of the trainway is, if it's thicker and stiffer, stronger, then it is much beneficial to hold the train. So more than a 018 bracket, 022 bracket is preferred. And so 1925 stainless steel is accepted as a finishing wire at the final wires. And so in many ways, we put from almost in the labial, we started the 016 night tie wires. And sometimes we go to 018, 020 stainless steel, and 1925 stainless steel. This one is stainless steel. The why? We have to put in some kind of, especially in the lower, put in some reverse curve of speed to level the lower arch more efficiently. Then put in a reverse curve night tie wires. The stainless steel wire have a reverse curve is more effectively, and then we can increase the amount of the reverse curve gradually after each month. And another way is that using the night tie wire 1725, 1925, then also we can put on the 1925 stainless steel. This is kind of 4 different types of wires. Maybe we can cross the here, and we can put on the more 1725 TMA wires as needed, but mostly night tie wires, 1925 stainless steel, or we can put on a stainless steel wire in the middle, and also we can go to 1925 at the end. Both which way we talk, our final goal of the leveling and alignment is put on the 1925 stainless steel as much as possible. And so we can, this is the general and typical wire sequences. But final goal is, as I said, 1925 stainless steel. Yeah, and initial leveling is very important. So in the modern orthodontics, if you done with the initial leveling and put on the 1925, it's almost done. And then the rest of the thing is that a matter of time, how far you go. For example, when we take an airplane, we are take off is very important and we have to, but once in the level, and it's a matter of time for the long flight. And at the end, everything is the landing is also very important. But in orthodontics, with the bracket, if you take it off everything well, the rest of the part is very easy. But if you have to control the anchorage with the help of the mini screw, then maybe you can finish your cases very well. Okay, so the initial leveling and alignment is so important. So put on the bracket at the same time and put on the wires. Oh no, it's not. So I will tell you. I will take a look at it one by one. So one is that when you do the initial leveling, especially in the extraction cases, lace back at the night tie wire is very important. So everyone, I think that you know what is the race bag, right? The purpose of the race bag is one is the axis control, prevent so-called robot effect, and to even during the initial leveling, with a heavy intermittent force by the lace back, tighten lace back, so you can move the teeth a little bit. And lace back is with the ligature wire, so a little bit thick one, 009 or 010. 010 is recommended, and then tighten from the first molar or second molar to the teeth here before inserting the wires. And why? As you know that the canine has an angulation at least 11 degrees or 8 degrees. It depends on the manufacturers, but anyway, they have a. So if you put in a bracket in a very good position, especially when the root of the canine is medially tipped, so-called in this situation, so you want to put it after leveling, you want to put in the root of the canine distally as a more good angulation. But in these cases, instead of moving the root, the canines, the crown is moved opposite direction, like this one. This one is happened. We can call this one robot effect. I also tell what is robot effect. But before, so if you want to move the crown, root, in real world, the crown move first in opposite direction. So this one is, and at the same time, this angulation, if you put on a very flexible night-tie wires, and it can produce the downside extrusion of the incisors, and after the leveling goes on, so-called roller coaster effect will take place. So to prevent from this one, by doing a lace back, it holds the crown here, and it gradually moves the root as the direction that we want. So this is the lace back is very important when you do it first. So by lace back here, and can, instead of the crown in the opposite direction, you can correct the root position that you want. So especially in this kind of thing from the beginning, maybe it's better to put on a bracket in the front later after you control the canine, and then maybe you can minimize the deepening of the bite or to minimize the so-called roller coaster effect. And also by the lace back in extraction, think about to put in a bracket in the front, no hurry. You can put in a bracket sometimes later. When if the root, you'll be able to control the situation, and if you use that bracket that has a lot of angulation, it is incorporated. And corrected axis of the canine root, and with a lace back, some researchers tell that there is a small amount of the retraction during the initial leveling. So activation, you can do them some 2 weeks, but 2 weeks, maybe you can call the patient every 2 weeks, but you can do the 4 weeks. After in this case, like this one, do a lace back, tighten it, and maybe this one is squeezed the teeth within the periodontal ligament space. So within 2 weeks, maybe the lace back getting very loose. It's loosened. So every 4 weeks, maybe I call my patient every 4 weeks normally. So 4 weeks is then, as you can see here, some spaces canine moved a little bit, and then it gives us some space to align the front teeth, and at the same time we maintain the root position, and then we can move to the more thicker wires, and 1925 and elastic, and at the end of we can sort of hook and mini screw for more retraction or anchorage preparation, whatever we need, and we can finish like this one. So in extraction cases, when you put in a bracket, at the very initial stage, lace back is very important. And another thing is the separate canine retraction, like this one. In extraction cases, and in this case, it's operational problem to put on a bracket, but in the lower, we sometimes use that kind of separate segmental spring to move the canine first, like this one. And then if the space gain, we can put on the brackets and lace back, but we didn't hurry. We cannot put on a bracket here, so this one called sequential bonding. So do not put on the bracket, every bracket at the same time. So strategically, you can skip the bracket from the beginning, and once the space generated and slightly, then we can put on a bracket later, and we can catch up them, and then we go back to the wires, especially night tie wires again. Then we can gradually finishing our leveling and alignment like this one, and then we can move as the situation. We can put in night tie wires or stainless steel wires with incorporated with some, if it's stainless wires, we can incorporate with some kind of reverse curve of band, slightly, moderately, and then we can move the more thicker wire as time goes by. And another thing is that we are using bypass wires. In this case, is extraction, but do not put on the bracket here, and then we go leveling first in the posterior, and then if the posterior is leveled a certain amount, then we can bend the stainless steel wires, and then we can retract these tears back. So there is two things. Number one is that never trying to move the teeth along the wires, flexible wires. It can cause, so we need a stainless steel wires. So this band is for patient comfort, bypass, and then we can apply the elastics, and we can move this one and this one. And if you, after that, if you have the space here, then we can put on the bracket gradually, one by one. As you can see here, space is created. Sometimes you can use the mini screw to hold that one. And then as time goes by, we put on the bracket here, and we go back to the night tie wire again, and then lace back and do a leveling. In the lower, we put on the bracket here, but it's a kind of leveling goes on, and gradually we move, wait, move, and leveling, and open the bite. Another one is that this kind of class 2 situation, deep bite cases, you can first judge it from how much on the full smile. You have to think about the exposure of the teeth, and especially the gum. In these cases, we are beneficial to reduce the gum smile. And then in these cases, we, rather than put on a bracket and trying to leveling the whole watch at the same time, then it can cause deepening of the bite, and later we have some difficulties in leveling this teeth. So as I told you before, in deep bite cases, I prefer to use that one in the past very much, and with the removable type, this kind of expander, sometimes expand the medial screw and anterior bite plate here. There is two purposes to use this kind of thing. Is that during the start of the treatment, we expand the teeth, especially like a class 2 situation, has a kind of, there is a adaptation of the teeth of the posterior to lingually tipped, so we are expanding on this one, number one. And another thing is, in adult cases, by doing a bite plate removal type, it can cause the bite opening with this kind of some kind of erupting. So, and the number three is that by anterior bite plate is work like some kind of stabilizing splint. So in young adult cases, if she have a kind of functional shift or TMJ positional change, maybe this kind of things that release freely, allow the free movement of the mandible. So maybe if there is a functional shift or TMJ problem, that maybe it can be helpful to detect. But for TMJ purposes only, maybe this kind of posterior discluded appliance should be avoided. But we are, as an orthodontist, we are going to dealing with some bite in the posterior also. So this kind of very initial appliance is very helpful. Number one, by the opening. Number two, some tooth movement. Number three, if there is a functional shift, and then we can detect. Anyway, as I told you, the role of vertical bowing, if you put on a bracket here, but in these cases, maybe the canine is tipped mesially, so maybe we can put on a bracket from the beginning, and the lace back, maybe the vertical roller coaster effect become minimum. So this is not a good sample. But if you have a canine angulated distally, then maybe you have to be very cautious. So mine is that the sectionally we put on the bracket, and then we not put on at the same time. But do you know, sometimes someone is very familiar with intrusion arch, especially suggested by Dr. Burston. Please refer to the fundamentals and what is the intrusion of the incisors. But anyway, this kind, we are not putting in the bracket slot. There is a segmentally leveling, and then we're trying to intrude first at the very beginning of the treatment. Night eye wires, and it has a band like a utility style, but it is modification of the intrusion spring. And then also we can put on a, sometimes you can put on a mini tube also in the 2x2 and use that one, and later you can replace by the bracket. But this one is bracket, but in the lower, maybe you can put on a small profile mini tube or something, but you have from the beginning, no problem to put on a bracket. But do not put on a continuous wire from the beginning, and after some kind of intrusive action, then we can change our, go to the continuous wires later on. And then after the ovobite and ovojet is allowed to put on a bracket, then it is time to put on a lower bracket like this. And we can continue to go for rest of the action. Space closure, leveling, and full arch retraction, and we can finish gradually. Yeah, and another thing is the sequential bonding like this one. So in cases you can not put on the bracket here, and you can use the open coil to make a spaces first, and then as the space gain first, and then you can turn and can engage the bracket little by one, and like this one, and you can finish. This one is not finished the cases. This one is to finish the leveling and alignment from the front. After front bracket, maybe this kind of small expanding spring that was made of small spring that made of the 018 stainless steel wires, and it has activation like this one, and then you can put it in a hooked it, and you can open the space, maintain the space, and also on the other side too, and we can finish our initial leveling and alignment. And sometimes we have to add more wires. Situation like this, mostly canines, or especially the lower, the lateral incisors tip distally and medially tip medially. We encountered many situations like this one. And if you put on a bracket here, and then the angulation of the bracket easily produce this kind of roller coaster we call it roller coaster effect, extrusion of the incisors, and the curve of speech deepen. So it is we have spent a lot of time to re-leveling this one. So in the situation like this, we didn't put the bracket from the beginning, and then once the other part is leveling, then we can bend the wires a little bit with the stainless steel wires. I prefer to use this 018 stainless steel and put on a bracket, and then overlay night-tie wires to correct this one. So during this one, this 018 stainless steel wires hold the rest of the teeth as anchorage, and the very small night-tie wires are acting to move the root of the laterals. So we put in the night-tie wires, 016 night-tie wires, and 18 stainless steel wires at the same time. But night-tie wires does not go all the way to the second molars, just 4 or 5 small portion, but we are acting to move the lateral incisors. So as the lateral incisors has a more angulation is corrected, then maybe we can put on the 1 wires, go back to 16 or 1725 night-tie as the situation, so we can finish like this one without producing roller coaster effect. And the roller coaster effect is not always take place in the from front. In this situation like this one, crossbite, we are trying to make a space first, and then with put on a small button or something, you can put it back, and the crossbite correction is the first. And then in the lower, as you can see here, the canine of the number 43 is located very buccally from the beginning, and we put on a bracket and we put on a night-tie wire. Then what you saw, what happened, this kind of, the night-tie wire is very flexible, so they change their form easily. So the arch form is deformed like this one. This, well, so but if you don't, we can fix it anyway, but it takes a long time. So here, but anyway, we continue to go for night-tie wires, 16 or 18 stainless steel, 020 stainless steel, 1925 stainless steel. Finally, the arch form. We can correct the roller coaster effect anyway, but it will take time, but we have to fix it anyway. So from the beginning, take a look at the cases, and if you put on the night-tie wires, they are easily deformed, so it can cause the kind of deformation of the arch form or leveling roller coaster like a situation can take place. So let's take a look at more in the arch wire situation. So everyone, especially passive self-propagation bracket company, they have a sample like this one, and the conventional one is that put on a O-ring like this one, and it caused many friction here. So instead of the bring down here, after leveling, the laterals and bicuspid is going up way, and then they ruin that kind of thing happen. It's easily solved if you escape from this kind of, prevent from this happening. The self-propagation, especially passive self-propagation, is without no friction in the both sides, and the wire slide out and minimize. After a couple of days, you can get a good alignment and leveling. Sometimes it's true, but even though with a passive self-propagation bracket, this kind of phenomena can be produced. So before, but you have to minimize that one. So in this case, like this one, without catching the canine from the beginning, just trying to leveling, and after the stainless steel wire, more rigid base wires, trying to make a space first from the beginning and pushing there with the go back like this open coil, but lace back night tie wire, but stainless steel wires, then putting it down, and it takes time. And this one is kind of some small trick to activate in the open coil, but anyway, so here we bend the stainless steel wire like this one, and then we can use the elastics or this kind of overlay night tie wires to bring the canine down to minimize the side effect, unwanted movement of the two teeth. Our intention is to bring the canine down. Anyway, later on we can change it more one wires if the canine down. And also in this lower is also like that, the angulations and what I'm saying, that if you put a bracket in the final position, then maybe it can cause another, during the course of the initial leveling, it produce sometimes unwanted tooth movement, as I told you. So expanding spring and overlay, help of the elastics, overlay to correct the angulation, and then, but sometimes some people, OT especially old people, elderly people, sometimes the teeth does not move that well compared to the young or adolescent patient, but we are struggling to solve the problem anyway. So sometimes we have to stop in certain point. Okay. Anyway, we are trying to give at best the angulation correction here, but he spends almost more than 6 years. I didn't, so we stopped here. But I want to say that give us some kind of information of the use of the leveling. In this case, it's the same situation. As I told you, the lateral incisors, and we are trying to leveling the. As you can see here, we didn't put in this two teeth, distally tipped two teeth, because of we don't want to deepen the bite. So this one is not yet finished the leveling and alignment, leveling and the posterior. So we put on the 18 now stainless steel, and we overlay this one, and we can finalize that one, and we can finish like that. Okay, so take a look at the other cases. Yeah, this. So from now on, I'm speaking on the importance of the mini screw, and the time is already at 4:25, so I have around about 30 minutes, so I go a little bit faster. So the mini screw is much more important in this interarch movement, so-called stage 2. In extraction cases, space closure, or non-extraction, full arch retraction and full arch protraction cases. So this one is that the expansion and anterior bite, and then it's unusual, but I put on a bracket in the lower first because I want to use this removable appliance a little bit more. That is only reason. And then I put on a bracket and go to the leveling, and it's 1925 stainless steel. I didn't try to pull the space closure or full arch retraction or total arch movement unless 1925 stainless steel with a hook or without hook was placed. So this time I hooked the mini screw here and trying to hold and retract, and this is a kind of small detailing band and elastics, and finished like this. And this is the before and after, and this is before and after it. And look at that root movement here and the small amount of the distal movement here at both upper and lower. And it is a retention 12 years later. And this is before, and it's at the D1, and then it's 24 years. So this one is a little bit gummy smile. It's a little bit this kind of situation, and I improved it at her late 20s. This is her 40s. You know, you look at the difference between the gingiva showing. So that means another clue that we are trying, as time goes by, as an aging process, the tonicity is getting down and the gingiva showing is getting less as we aged. So when you're treating the patient, please take a look at closely look at the gingival disposure at the pool smiling. It is very difficult. It is very important to determine whether we intruded the upper incisors or not. And this is I treated her 2 sons nowadays. This is 18 years of retention. The sons are growing like this one, small babies. So, but it was always possible with the help of the mini screw with minimal patient or cooperation and no oral traction. And I heard that many of you are using mini screw. That is a very good news. So as an orthodontic tourist in the past, and the brackets and the wires is considered as a very crucial factor. But nowadays with this kind of stripper and mini screw is a part of very important thing. And today I heard that you are using mini screw, so I not talking about the where and how put on the mini screw. I didn't mention it, but you are now already expert in putting a mini screw, I think. And I skipped a little bit faster. But when you put on the mini screw in the palatal side, I strongly recommend to use the motors. Maybe Osstem also has a very good nice motor driven. It's a handheld cordless so-called e-driver. So very strongly recommended from the mini screw in the palatal side, and you should use that one. And if you go to the YouTube, you should go to the YouTube channel and searching the Osstem Orthodontics and when and how to use orthodontic screw. There is with the orthodontic I made this one with them, and you can find the movie clip. There is a 12 movie clip, and where and how to put on the mini screw. So if you go to the YouTube channel, Osstem Orthodontics, and then you can search when and how to use orthodontic screws. And there are so many manufacturers. They introducing many different kind of mini screws. I using from the beginning, from almost 25 years ago, from 1996, and the Koreans made a very good quality of the titanium made mini screws from very early in the 2000 new millennium era, 2000. But this is a very good quality mini screw that Osstem held in. So I introduced briefly, shortly, Osstem mini screw. They have 4 different type of the head, like small, and they have also the 2 different types of the surface treatment. One is the etch or machining it, but because the Osstem is basically originally the company who made a prosthodontic implant, they are very strong in surface treatment, but for the and they have different diameter of from 0.2 to 0.8, and they have different lengths, 6, 8, and 10 millimeters. And they have line up like this one. The gray one is referred to acid etch surfaces. This was a machining the surfaces, and there's a difference from the head type, smaller one and hole here. If you among this one, if I ask to choose one, my preference is this one. This kind of machine and that has a hole here, and this one is that. But if you can buy many other purposes, you can use other types. But for me, if I have to choose one, this is my choice. Okay. What is the value? The precise anchorage control, that everyone knows that in extraction cases, the anchorage value, sometimes they call maximum and moderate and minimum anchorage cases, or type A, type B, or type C, or retraction, attraction, and protraction. The retraction, attraction, protraction classification was made by Dr. Burston. He make an 8BC type anchorage. So type A anchorage means that mostly the extraction space should be closed by the distal movement, the anteriors. So maximum situation like this. But yeah, he is definitely very protrusive. What do you think? In the Hong Kong's doctors, still you think you agree with me? Yes. So this is not a diagnosis and treatment flange section, but anyway, we decided to extract it upper 2 and lower 2 for bicuspid extraction. But what you are most thinking about that her incisor inclination is still upright from the beginning. That is our challenging situation. And crowding is very minimum in the upper. We have no problem. Difficulties to leveling, but as I show you before, we are trying to bring the canine first a little bit. And here, as the crowding relieved in the lower, the extraction space almost closed. But still, there is a lot of space remaining in the upper, and we have to close the space. And when we need a space, strong anchorage to close the space, mostly the anterior retraction, maximum anchorage cases, we need the help of the reinforcement of the anchorage. The best way is to mini screw. But when you put on the mini screw here, somewhere here, and then we can pull that one, this kind of moment is take places easily. So this is just everyone know, I think. So when you pull here, the whole segmental rotation is take place. So like this. So this one is just same ample, yeah, and occlusal plane change, and anteriors getting down, and posteriors going up. So bites can be different, and anteriors, especially in the upper and lower, go uprighted. And if it, as I will show you that if this kind of phenomena is okay for you, you can use that one. For instance, for example, in treating the open bite cases, you should use this kind of things happen actively. But you, in a deep bite cases or extraction case, if you open the bite or maintaining the bite, maybe you should avoid this kind of things. So in these cases, maybe we are strongly recommended to use a spur or lever arm, whatever called, and to direct the line of forces as close as to center of resistance of the anteriors closely, and so minimize that the changes. So there is two ways. One is that from the mini screw, directed forces to the arch wire or bracket level, or parallel, or more upward the center of resistance, and as it needed. So this cases that we use that one with a lever arm or hook, or same with the center of resistance or more higher than center of resistance. Then maybe we can use a very long hook or spurs. But if the longer the hook, maybe it irritated the patient. So in these cases, but we can bend the hook a little bit, and then we keep the while we are maintaining the line of forces, but we can minimize the patient discomfort, but we reduce the span a little bit, but you can control the forces, amount of the forces, but you can still use that one. Or if you use that more bending the hook, or just a small, medium or small hook, you can apply, maintain the line of forces almost parallel to the arch wire, or you can direct the forces from the mini screw to the arch wire level like this one, and then maybe you can produce this kind of rotational movement. And so in this, so you can control by, you can do the crimpable hook like this, or, but I prefer to do soldering it. So this is, okay, this is the clip that make a solder hook. Maybe you can purchase the solder hook. This is a silver solder, and I make like a small spring here. And then with the 0.7 millimeters stainless steel wire that was made of Adam's clasp, or in many removable plate, they make a labial bowl sometimes, you know. And with this is the clip that made a small solder ball, and with the wires. One, two, three, then you can dip in the cold water and cut in the middle, and like a solder ball, it's become like a Hush chocolate. And once you are, it's a 1925 stainless steel wires, mark about 2 millimeters behind the canine normally, and put it in the stone like this one, and with the wet gauze, isolated the position that we want to solder in the hook, the wires, just the positioning there, the mark position of the solder hook and with the wires. But the important thing is that when you do the soldering, do not guide escape, prevent from the frame go directly to the main arch wire. Then it can anneal, and then it can lose the strength. So when it's doing that soldering, apply the heat only here in the kind of spur wires. Take a look at again. Yeah. So when I have kind of courses in using mini screws, and I put an emphasis on that soldering. So, oh, sorry, this is made wrong. Is it wrong? Do not directly apply the heat in the main wires, just in the wires. So many people call this one as a transferring soldering, applying the heat in the not in the main wires, but here in the spur wires. Spur wires can be anneal, but it's no problem. But main wires maintain their stiffness without annealing at the solder point. So most of the time, I do not do this soldering by myself. My steps always doing the soldering, but what I'm doing that if you bring the soldering wires, then I can bend the hook like as the length that is needed. So in these cases, we do need the root movement and bodily movement more. So I bend the hook a little bit longer as much as, and I hooked it a little bit, and I put on the mini screw in between 6 and 7 here in these cases. So what I'm saying is that if we, as an orthodontically, there is many requirement for the well-finished cases. Everyone know that crowding, spacing, arch form, flat curve of speed, inter-incisor angle, adequate overbite object, inner dilatation, root parallelism, crown, and see all the so-called the joint is coincide with centric occlusion and the midlines, gingival incisor showing, and concave monarch, and we have to put on the teeth in the center of the alveolar bone for more healthy periodontal condition, blah 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 blah. Yeah, I think that you are familiar with this one for the ideal occlusion and what is the goal of the orthodontic treatment. But if you don't have much time, then we have to take 3 things, and the most important thing is when you finish, we have to do the proper torque control, especially in the upper anteriors, and the bite should be open sufficiently, and the lower adequate uprighting of the molars, especially lower. That means bite of the lower leveling, and inside the torque control is very crucial. And the proper torque, bite opening, adequate uprighting of posterior teeth is very, very important, especially proper torque control, especially in the extraction cases. It's very, very important, because if they apply the teeth only, anterior torque, if we are trying to do an anterior torque control, our intention is to move the root, but rather than a root, the crown moved the first in the opposite direction. This is called robot effect. Once again, if we try to move the roll in the water, root the boat, the crown, move first toward the opposite direction. This is the natural phenomena. So we try to move the row, but in the water, the row have a strong resistance. So instead of the row, the boat in the opposite direction moves. This is a rowboat. But if you really want to move the row, then we have the strong anchorage here. And then if it's very hard, but we can move without moving the crown, we can move the root in the bone. This is the rowboat effect. So we need a strong anchorage. So amount of the tooth movement is also very important. But when we try to do that one, to kind of movement, we need a strong anchorage. So that's why one of the reasons that we use the mini screw. So strong anchorage, so we can control the movement. So the value of the mini screw is that we can move the teeth more accurately that we want, more than an amount of the tooth. So, and upper toe control can be done easily using pre-adjusted bracket. So everyone nowadays use pre-adjusted bracket, right? Some people still use the conventional non-HOI bracket, but I think that this kind of HOI bracket is only for educational purposes. But nowadays, with a strong pre-adjusted straight wire appliances, we have to know the things. But anyway, we are using pre-adjusted bracket. They have a torque inside and level arm in extraction arch. And sometimes we need a third order arch wire banding because there is a play between the wire and slot. We need a third order band if needed. And we trying to use the toe control, then we need a strong anchorage mini screw. So I strongly recommend it even in the straight wires. You have to know how to put an anterior lingual or labial toe in the anterior portion. In this case, is to bring the molar, bodily movement and root movement, the long retraction. I put on a 10 degree from the beginning, and I up to 30 degrees, and I gradually increased every 10 degrees per month. So here, low is almost the space is closed, but there is some space here, so we need a kind of bite opening and lingual root to torque in anterior, upper anteriors to close the space. There is no overbite and overjet here. So if you try to do a lingual root to torque, then it go forward. So I finished. Yeah, even in the long retraction, I maintain almost the upper incisor torque. Yeah, another one is that we extract, if we extracted this in the other cases. This one is that she need to complain about her protrusion, and she want to retract her teeth, front teeth back as much as possible. But in these cases, during the time she came running to my office, and then she said, "Oh, doctor, I don't want to retract anymore because my husband in the breakfast table tell me that you look more older." So that's why we are thinking that, so we have a mini screw and we bring the teeth forward, back teeth, and then finished. And she find a new big broad smile again. But what we found is that we bring the molar forward more, much of the time. So maybe people classify these kind of things as a type C anchorage. Okay, but in this case, because of the time, I go a little bit faster. Yeah, this is class 2, though I don't want to retract anymore. So, but class 2 division 1, and I want to recommend some kind of surgery, but definitely she don't want. So we try to leveling, and then my intention is to maintain and improve her, not to ruin his profile, and to bring the low teeth forward as much as possible. And it will take so long because in here you can see the small gap, but there's no big difficulties, not that much difficult to bring the bicuspid forward. But in the other cases, to bring the molar forward is very, very difficult. It takes a lot of time because of the width of the alveolar bone is smaller than that of compared to that of the medial-distal, the buccolingual width of the molars anyway, and root. So we finished that cases, but it takes 4 years and 5 months. Yeah, but this is before, and comparison here, before and after. So as a profile-wise, this is right side is after. Then I try to ruin his profile, and then I try to maintain his profile as much as possible. So that's why we bring the molar forward. This one is called full arch protraction compared to the full arch retraction in the upper. Yep. This is 10 minutes. So I go for a little bit more. Yeah. So you can use the mini screws, some incisor showing, and as I try to intrude it, but the simplest way to put a mini screw here and trying to intrude upper incisors. Vertically, we sometimes put it in here, but we prefer to use that one. And I think that you have this very similar cases to intrude, to reduce her gummy smile appearance, debonding, and then right after that we do a kind of a gingivoplastic periodontist. So this one inside in the rest position, the incisor showing is that I think that minimum, but more than incisor showing, we have to evaluate the gingival showing at the full smiling is very different. This is before and after, and but the importance is that the mini screw is the change in extraction and non-extraction versus extraction and non-extraction is very, very controversial. And back in the 1980s, we have a conference to extract and non-extraction. This patient is not that much crowded and protruded, but she came to her protrusion because as a professional modeling, many cameramen. So we treated not extraction, but we have to think about that, how many spaces we can get. Lateral expansion, sometimes we do need a lateral expansion most of the time, and everyone knows that 1 millimeter of expansion has given us 70 points of the arterial gain. And you do once put on a mini screw, and then we can get a 2 millimeters more distalization of the molar for one side and by 4 millimeters. And sometimes we do interproximal stripping. In adult cases, especially, do not do the interproximal stripping in the growing patient. It can cause the cavities or something, but very small amount of this kind of movement can give us totally 7 to 8 millimeters. But the mini screws distal driving is only 2 millimeters. This is a guideline, so maybe it's vary from the patient to patient. So it is the removal appliances, and then leveling, and then we started retraction with the mini screw, finished. So the one is the 2 millimeters, about 5 millimeters. So this one, 7 millimeters, is fall into the attraction, moderate anchorage in extraction cases. So before the alignment, after the alignment, so her profile is a little bit, and then we put on a mini screw. Sorry, mini screw, and we're going to from beginning and the end retraction. If you do need more than this one, in this case we don't need any more retraction, but if you do need more than 2 millimeters and 3 millimeters of the spaces, maybe you have to think about the extraction or extraction instead of the non-extraction. Okay, I will skip a little bit, sorry for the I have several cases, but before we go, non-extraction, extraction is I want to spend a little more time, but in Korea, after crowding, non-extraction, we should do distalization, the full arch, little bit. So 2 millimeters, if there is a 2 millimeters, then maybe we can save most of the time. So when you all take it to all consideration, keep in mind that the 2 millimeters that we can get a lot of space, but when we do the non-extraction and whether we do distalizing the whole teeth, take a look at if there is a space. So one reference is that by Echiko Endo, who had passed away, very famous Japanese orthodontist. She suggested PM line, so pterygomaxillary to the here in the PNS. If the line, she is said that all the teeth should be located in front of the PM line, but this is another reference, but we have to take a close look at the patient mouth, whether there is a space between here and here. And so if Dr. Burson is still alive, I will ask that, okay, why we should extract the teeth and doing a more type C protraction, why you have to take an extraction rather than type C anchorage. If we can distalize more, about 2 millimeters, then we can solve this kind of situation easily. And from the back, this is my clinic from 2005. The blue is the rate of the extraction, and this one is the non-extraction. So from 2015, my extraction rate is getting down, or less than 10% in my practice. So still, everyone is non-extraction, and extraction is very big issue. But nowadays, my pendulum to non-extraction decision is much inside of the non-extraction side. And before we close, I said the importance of the protocol control. So I finished with these cases. This case is transferred from Vietnam for a long time ago, and the former doctors are doing a great job to close the space and maintaining the job. And she came to my office, she can finish these cases, take off all the braces about 3 months, within 2 or 3 months. But I said, no, I need more here. Then you can have the upright teeth like this one. So I said, okay, take her out. I do need if you did a great job until now, but what I've done is finishing procedures. I wanted to correct another one, so I given another additional torque on the wires and bring it down, and I cooked it for almost 10 months to give a more inclination and torque control in this beautiful boy. And this is as you can see here, this kind of number and the incisor angles and so-called the inside guidance should be shallow than the condyle guidance, blah blah blah. But yeah, so she finished like that. At the time she firstly came to my office, and this is you can see the little difference at the finishing. So this is before and after smiling. Little change it. So after she go to the military service, I lost him, but anyway, this is a 1 year's retention. Okay, so orthodontic tools means that mini screw. Everyone know that you are familiar with the mini screw, and this one is very important and become a crucial component in our daily practice. So the mini screw use is only limited by the limitation of your imagination. So I always said that this one is old soldiers, and this one is a very modern soldiers who equipped with the modern weapons. Maybe he can kill the modern soldiers, but the modern soldiers who are equipped with the modern gun is much more possibility to win at the war. So we are now, if you go to your clinic, and so you have to compete with your doctors, and you are seeking for more simple way, but at the same time you have to treat the teeth more accurately. So orthodontics is not the game who move the teeth more than long way, how far. No, the orthodontics is the game to move the teeth exactly where we want and where the tooth should be. So many good bracket, Majesty and OK and mini screw and small tube will help to accomplish the mission. So this is thank you very much for your attention, and this is my talk of today, of the 3 hours. Thank you. So if you have any questions, please feel free to ask me.